Yeah, anybody else that wants to leave their microphone open, if you have questions, that's totally fine. It's a small crowd, so it's informal. So if I'm going over anything, or if somebody has questions or something that doesn't make sense, or wants me to go over something again, or speak louder, please feel free to just to speak your mind. Okay.
The audio is good, by the way.
Okay. So that microphone, that's not us, right? Correct. The one Kevin.
Yeah, that's me.
Oh, okay.
So
Great.
You're good up here.
All right, guys. So my name is Dr. Vemulapalli. I'm a urologist here at St. Luke's Hospital, and I do a lot of urologic cases. And one of the things that I really enjoy doing, and I have some extra training, is in robotic surgery, robotic urology, and that covers a wide range of procedures of oncology versus benign disease versus stone disease. And so I'm just going to talk about some of the experience we've had here in the hospital, some of the conditions we've treated, what robotics is. I know it's been around, and it's been, I know in the lay literature, sometimes it's on advertisements and in magazines, but I still have patients that come in and have a lot of questions and wondering if it's, I recently had a patient ask me if it was like an R2D2 doing surgery. So it's, some of these terms can be confusing, but it's not as complex. So hopefully this will help to demystify what robotics is, how do we use that in surgery, and what is it that we're doing here locally at St. Luke's to help take care of our patients. So this is just about me, just an idea, who is this guy? So I'm originally from New Jersey. I went to medical school in Boston. I got an MBA while I was there. I did a 6-year surgical residency in urology, general surgery, as well as urology. And then after that period of time, I did a robotic surgery fellowship at Ohio State University, which is the largest robotic surgery program in the United States, or at least at that time. So how do we?
Excuse me. There seems to be quite a bit of an echo.
Anything, Kevin? You think anything? Is it on our end? You think, or
it may be on their end because I'm listening through here.
Okay.
It's okay.
Yeah, maybe at this point, then, if as far as I know, I think that the audio is okay on our end. Maybe folks, keep your microphone muted unless you have a question or like something to say. Sometimes I know doing some of these Zoom meetings, that can be a source of reverberation and echoing.
Is anyone else experiencing any echo?
Get backwards.
Try it again.
Yeah. So this is just some of the highlighting some of the procedures that we do. Robotics, quite frequently, we do a lot of radical prostate surgery for folks with prostate cancer. Sometimes we do prostatectomies also that are not radical in nature, meaning radical is usually a term that's described if we're using something for an oncologic, for a cancer point of view, where we have to remove everything in its entirety. We do a lot of kidney surgery. And if we were removing a portion of the kidney as opposed to the entire kidney, a lot of times we do that robotically, because robotics allows us to do a lot of reconstructive maneuvers and pyeloplasty and urethral reconstruction, and also for bladder surgery. And this one picture I think is really useful. So with the surgeon's hand, typically that's for, as much as doctors have been doing surgery, it's been with our hands or through instruments that were larger. These instruments that are doing now the robotic portion of the procedure are much smaller, much more delicate, but they do give us that entire articulation of our hand, just as if, it would, instead of just maybe stretching or going up or down, we're able to really kind of get into something in a 360-degree circumferential fashion, really doing maneuvers, which is really where the reconstructive aspect of this procedure has really opened things up for us. So what are the advantages of using a robotic platform? And what a robotic platform entails is that once we've placed our access into the abdomen, we have these small instruments that go into the body, and we control those instruments at a console. So what happens is that the surgeon looks into the video monitor here, and it's the robotic camera has multiple cameras in it that give you a three-dimensional picture of what's going on. So imagine when you're watching TV, you're looking at one plane, you're looking at something flat. When you're looking at this robotic console, it's almost if you had virtual reality goggles on, but you're actually looking at a real picture in 3 dimensions. So you have the element of depth. So when you're working on something, you can get around it, elevate it. That perception of depth really allows our ability to improve what we're doing. Sometimes for surgeons, if they're working on something really small, very fractions of a millimeter, it really also takes out any type of hand instability that you might have noticed previously. Before, patients would ask you, like, does your hand shake or anything like that? Nowadays, using a console like this, when you're working on such ultra small microscopic things, not only are you getting the magnification of the camera, but you're also having that robotic instrument really operating without any excess tremor or things of that nature. The magnification is immensely important. When I was mentioning, we also do a lot of prostate surgeries. Before we started doing these laparoscopic or robotic procedures, the average blood loss on a radical prostatectomy, meaning someone who had extensive prostate cancer in the older traditional procedure, was anywhere up to 1 liter. The human body carries about 5 liters of blood. So on average, blood loss for that procedure, on average, and this talking major academic medical centers, UCLA's, Johns Hopkins, Mayo Clinics, was about 1 liter, 20% of your circulating blood volume. With this magnification, we can really get right on top of blood vessels, throw our sutures, so that nowadays, most of my cases for robotic prostatectomies, I'd say the average blood loss is between 100 to 150 cc's, which is really negligible, so much so that really the age of transfusions is very much, it's not something that we commonly do. Rare cases that we're, actually pushing the envelope of doing these procedures, patients that need to be on full anticoagulation for mechanical valves. Say, for example, that patient also has significant prostate cancer and undergoes a procedure like this. Those are the patients that sometimes you're really having to be mindful of that need, immediate anticoagulation for other conditions. But in a normal procedure, blood loss is really very nominal at best, minimal. So again, this is an example of what the platform, we use that term, a robotic platform. And so it encompasses not only the console, and this is where the surgeon is sitting, and this is the area where he's looking through with the stereoscopic vision, so that you're seeing things in multiple dimensions. The console, we usually have an assistant down here, and those instruments are going through the abdomen with the patient on the operative table. And also, there's also a monitor here, in addition to other monitors that we have in the actual operating room. The robotic console also has some of these monitors that if you need to kind of point to certain things, almost like a telestrator. And you ever see anybody that watches football, or John Madden would make a circle, like pay your attention here. That's another way that we can say, hey, this is something that I want to, before we get into the nitty gritty, I want to make sure that we're all on the same page. This is what I'm trying to do, because now the surgeon is sitting over here, not right on top of it. So before we get into anything where we're time or our attention, we want to make sure that everybody's on the same page. We can go and telestrate those maneuvers and say, this is what step 1, step 2, step 3, so that everything is just routine. And so initially, when I started my training, we used to have what was called a Da Vinci S. It was the first type of Da Vinci robot, and it was first developed for cardiac surgery, doing minimally invasive coronary artery surgery. When they would do, people might use the term, did they have a double bypass, triple bypass, that sort of thing. That was initially developed to do those for certain type of cardiac surgeries. And we, as urologists, saw this and, kind of took it over and tried to incorporate it into some of the things that we were doing, particularly because where we operate is in the confines of the bony pelvis. We're oftentimes putting our head down open wise, working over here. So now we can have our instruments underneath the bony pelvis and still work, with that depth 3-dimensional perspective. So when we initially came to St. Luke's, we started with the, we had an SI model. The St. Luke's Hospital was the first hospital in the entire Hudson Valley to have a surgical robot. And this was going, before the 10 years, that I got here. And then since then, our volume had increased. We upgraded to an SI model. And now currently we have a Da Vinci XI, which is the top of the line robot. And basically what these platforms do is that they have more articulation, have more device capability, more angulation, more better optics, smaller incisions, things like that. So that's kind of where you go from the initial model here, or this is actually the second generation model up to where we are now in the current sphere. I have to click on it.
Click, sometimes yeah.
All right. So these are examples. Like I think before I showed you, and these are about a few millimeters, but these are the different varieties of the instruments that we have. As these, I think before. So you have all these different kind of little areas and instruments. What's at the end of this that's actually going inside the patient are these little devices here. And sometimes you might have a scissor. You have different type of vessel. This is called a vessel sealer. And these are obviously quite magnified, but they're probably, to be honest, no bigger than, a pinky nail, so to speak, in terms of how big they are. So when they're actually inside the body, and they're all used for, some of us in urology use certain things. In the robot now has really been adopted across a lot of broad specialties. GYN surgery uses this quite frequently, as well as general surgery doing various procedures. And in order to accommodate all those different specialities, there's different instruments to accomplish these different tasks. And that's what essentially these different devices are for, whether they're graspers, retractors. Most of, I'd say, 90% of what I do, I end up using what's called a monopolar scissor and a monopolar grasper and a scissor, and sometimes also use a grasper here. And so this is like when a patient has surgery, typically we put those patients into a certain position. And so one of the things that we're doing is obviously, do no harm, right? Everything else, robotic surgery, minimally invasive surgery, all this stuff is well and good. But ultimately, we're trying to take care of the patient in a certain fashion. And so therefore, we're always very important how we position the patient. We're using a lot of this egg crating to make sure that the arms are appropriately padded, the hands are appropriately padded, and then we're placing them on a rope on the table. The table has to be flexed to a certain degree, and the patient is secured, obviously, in different points to make sure that there's nothing that really affects them negatively at all. And so these are for different procedures. These are the ports that we use. And so we'll have a space here where the camera goes in. And so when we're doing prostate surgery, for example, above the belly button is where I like to leave the camera trocar right here. So as the camera goes in, it gives me a wide view of the entire pelvis. Imagine it's a Y shape, as you go in and the patient is tilted, we're looking at the entire confines underneath the confines of the bony pelvis. So we have that entire space that we can have a good vantage point on. Sometimes, if we have to take out lymph nodes or other samples or other tissue, we sometimes, have to send those to pathology to see if there's anything. And so we have a little bit of an assistant port here that's a little bit larger to accommodate removal of any specimen. So if it needs to go to the pathologist, they can say, Dr. V, I looked at those lymph nodes, they're negative. So we can go, everything is confined and we can proceed with our procedure. And these other ports, these are about 5 millimeters or so in diameter, 5 to 8 millimeters. So I roughly equate it to about the diameter of a dime. It's probably a little smaller than that, but in your mind's eye, you can imagine that the width of these are about the diameter of a dime. And so for prostate surgery, many times what we'll do is we'll go through the midline port. At the end of the procedure to remove the specimen, we'll remove it right here through the midline, because right between the muscle bellies, there's a little area called the linea alba where it's just fascia. And by going through that area, you're not dividing any muscle. And therefore, that's really where less muscle trauma allows these specimens to be removed and allows improved recovery because you're not violating the muscle as much. And, to be honest, we want patients getting up and walking that day. So the less trauma to muscles, we can create, the better that recovery is. We're heavy taskmasters in surgery. They get no rest. The hospital's not a place to rest. We want you that night. We want you breathing well. We want you moving around. So the less muscle trauma we create, the less ability you have to recover. So again, when I said that, when we're looking through that camera port, we're looking from this camera port down into the confines of the bony pelvis. So what are we seeing? So this is where it looks like. So again, all the tissue, imagine, has like these, it's all in covered in this layer of fascia and other tissue. So you have some of the intestines coming down here, the bladder, some of the blood vessels that will go further down towards feeding some of these organs, also going down towards the leg. And so imagine in your mind's eye, this is the pubic bone right here. This is looking in cross section. So if you looked at somebody straight down the middle, just to orient you a little bit, it's not a whole lot of working space. So before, we'd be tilting our heads trying to get a vantage point down here. Now with the camera, we're looking at this, but in our three-dimensional mind, this is the pubic bone, this is the bladder here. In a male pelvis, this is the prostate, seminal vesicles, and this is the colon and the rectum coming behind it. So what we're trying to do is to work in this space down here, coming from this angle. So when we're looking at it head on, this is essentially the organs that we're looking at. And then this is it looks like in cross section. And obviously this is also dependent. This is like an idealized view of the anatomy. Oftentimes someone's had prior surgery, you're using your three-dimensional mind to kind of put back together where things should be. And again, this is like an area of the prostate. So I put this in view because, as I said before, years ago, when doctors would do this procedure, you used to have a lot of potential for blood loss, which was just expected. The reason for that, and especially in prostate surgery, is you have an area here called the dorsal venous complex, a big, large venous plexus. Imagine you have a bunch of tributaries of large veins. So sometimes when you're trying to get into that space, it could be a little bit harder to control bleeding from this area. And sometimes that could be potentially where a lot of this blood loss came from. Nowadays, because of that vantage point of where we're looking on, once we brought it, we're right on top of this. That will be right here underneath the pubic bone. And now once we're able to look at it from head on underneath the pubic bone, we can drop some of these tissues, and then we're able to put our sutures exactly right on top of it so that we're able to really minimize any excess blood loss. And so this is another picture of where all those blood vessels are coming from. So as we're looking into the pelvis, we're coming straight down, looking at, and so we're able to get control on these almost minutely. And that's really where the advancing the ball in terms of blood loss has really come from. So, some of the patients we deal with have for religious issues are not really, don't want to get any blood transfusions or blood products. And because of that, sometimes this procedure has really increased our ability to care for some of those patients. And again, this is like that area here. So imagine these are the two robotic arms coming here and trying to get direct control over that dorsal venous complex. And so you'll see just exactly, and this is all an accurate rendering of how big those instruments are. So they're very small, but they're doing very fine, very focal work. And once we're able to use our instruments, we're kind of being able to drop the bladder, coming across. And so the area of the urethra, sometimes when we do prostate surgery, one of the things we're trying to maintain or preserve is continence. And to do that, we're really trying to control as much of the external urethral sphincter, and the prostatic urethral length is very important to do that. And so because of that, we're able to get point control right on top of the prostate, bring it down so that we're able to divide it right at that junction to preserve as much of that sphincter as possible. And sometimes, there's other concerns. If, you're looking in this procedure and say there's a big area of cancer, like a big nodule that you see, you're able to kind of bring that down and make sure you resect it. And that's hugely important. Sometimes we'll do MRI studies, things like that, to get an idea of just exactly how much, cancer could be going on, or what is the anatomy like. But it still, comes down to, until you get right in there to getting to all these structures, that you're able to make, use your judicious nature, having seen these procedures, where can I come across, where's a safe area, how can I get all this cancer out and still, do what I need to do in order to maintain continence for this patient and things like that. And that's something that I think robotically is very useful to me in my practice, just from the visualization. That magnification is tremendously important. Before we used to use a lot of what were called loops, like almost little magnifying glasses right on top of our face to try to look at this. But now you have a camera that you're able to zoom in. Just imagine like you're on your phone and you're able to zoom in on a picture or spread it out so you can get a real good picture of what you're trying to do. You know, we're not better surgeons than the doctors that came before us. We just have better tools, and we're using some of those better tools to try to take care of our patients. So again, also something that's been hugely important. So again, we're getting the same articulation as with a hand as we are with the instrument itself. And that's hugely important here in prostate surgery, because as we're doing this, as we're connecting those two areas, once we've removed the prostate, we're bringing those two tissues back together again, and we're able to do a contiguous suture anastomosis, you know, because of that visualization and because of the articulation of these instruments. Whereas prior years, when you would do this procedure open, you'd be able to put one suture here, one suture there until you're able to bring the tissue together. But this really allows us to really bring what we call a mucosa to mucosa anastomosis to really minimize chances of any kind of problems after the procedure. Bladder cancer surgery. So I've left this just as an example of before, and this is a procedure we've been doing quite a lot of, or more so here at St. Luke's. Compared to, you know, when I first started, and this is for invasive bladder cancer. Before, traditionally, you know, you'd be making an incision from around the belly button all the way down to the pubic bone here, trying to get right on top through all the muscle area, trying to get right onto the bladder, using our retractors to make a space to try to get into our working area, finding the bladder, trying to identify all these blood vessels that are coming, lifting the bladder up. And again, so we'd also have to find the ureters. Those are the ones that are carrying the urine to the bladder. So once we've got the bladder, then we're dissecting out the ureters. We're using our fingers to get into that space to identify the ureters. And so this is an example, you know, you can see, and this in bad cases, patients with bad cancer, we still do this open procedure. But in patients that are amenable or have a body that or abdomen that can accommodate robotic surgery, this is an example of what a hand looks like and what the instruments that we're using now to get in there to do these dissections with. So it just gives you an appreciation for how fine the dissection that we're able to do nowadays. And essentially, these patients, when I do, they're able to leave the hospital much faster. And a lot of that is because of the fact that we're not making big incisions. Everything is more focal, fine, getting right on top of blood vessels, so our blood loss is less. But the amount of time that we're opening the abdomen to remove this is much less. So there's less fluid dynamics. There's less edema in the inner aspect. So the tissues are getting less swollen. So everything's able to start functioning sooner. In prior years, if we're making big incisions, we're plicating the tissue more. So there's more chance of fluid to go between the membrane of the tissue, the membrane of other tissues before it can adequately start perfusing. And that time of edema, I believe, is really what creates a lot of these problems and hiccups that keep patients in the hospital. And I think this is really what we're able to do this procedure well, get patients in with minimal blood loss, get them out, get them walking around, get them back on a diet, and getting them ultimately out of the hospital faster. And so again, I thought this was just useful, and I put this in specifically to show you, and this is exactly what we do. We use our fingers to open up the channel, separate some of this tissue, and you can see just now if we're doing that robotically, just with the difference in caliber of that opening. So if you can just appreciate, and these are what those same instruments that I showed you initially, so but it can give you the difference in the dimension. So, you know, there's really no greater dissector than the surgeon's finger. Oh, did I just do something? Oh, so there's really no, when I was in training, somebody told me this, I thought it was like, it stuck with me all these years. There's no better dissector than the surgeon's finger, and that's true. But realistically, having this caliber size difference, and if you can use this appropriately and have an idea of what you're trying to accomplish, it really opens up a vast forest of, you know, a space of things that you're able to do and accomplish with just much less trauma. And so this is just, this is a picture in Asia. I just got this. I was looking through the internet to find pictures of robotic surgery, and I couldn't, the still pictures I was taking on my iPhone and didn't do it justice. But this is an idea of what those instruments are like as we're trying to open up that same space here over the ureters. So I'd like to show you what the caliber difference is, and that you're making these fine focal openings, you know, right on top of it, as opposed to making larger incisions. And again, this is as we're coming down onto the bladder here, we're making these focal openings right into that area. And we're able to put clips onto blood vessels as we need to. So as soon as we see those sort of, and I think there was something here I wanted to show you just to, so as all these blood vessels, if you see something large, you're able to focally clip that area and stop that bleeding, as opposed to doing large scale maneuvers to try to control that. And it's that focal dissection that creates less trauma, less bleeding, and ultimately, I think, better recovery. And so this is after we do the bladder, we remove the bladder. This is something I still do with a smaller open incision, where we have to harvest a piece of the intestine, and then we create a new reservoir where the ureters are now tunneled into, and then this now comes out to the belly as an ostomy. But realistically, the incision we need to make that, and I do that with one of our general surgeons here, Dr. Reichman, we're able, that's usually probably about 5 to 6 centimeters, which is probably about yay big compared to, you see here, the older, more traditional way of doing it, you know, from belly button down to the pubis down here. And because of that, I just think that the amount of recovery is less, because you're going from essentially an incision that's from here to here, as opposed to from here to down here. And this is no different than the procedure that we've been doing for many years. We're able to just do with smaller incisions in a way that's just less traumatic to the body. For kidney cancer, also similarly, this is what the normal, you know, to remove what we call partial nephrectomy. So if you had, for example, a kidney with blood supply and you see a growth like a tumor here, sometimes you want to be able to resect that tumor or remove this over here. And we try to remove a part of that kidney wherever the problem is, as opposed to removing the whole area. And in years past, how we all trained with larger open incision to control everything. And these are what some of those incisions look like. This is called a thoracoabdominal incision. This is a midline. And so these are all different approaches to control that. And again, just as we've able to change some of the areas of where we're doing, instead of needing our whole hand in there, we're able to do it with these smaller instruments because of that articulation aspect. So imagine if you cut open that area of the kidney, you need to be able to compress this kidney, and it might be in more than just a linear one dimension. You might need to bring tissue together from different parts. If you're getting close to where the urine is collecting down here. And so it's that area of using all these different instruments to be able to articulate your wrist, to be able to get those. And so when we do this kidney surgery, this is oftentimes where those ports go in. And for something like this, just like in the prostate, you sometimes do need to make a small opening to remove that tumor so that you have pathology, so you can compare the margins and so on and so forth. But usually it's just enough to accommodate exit of that lesion, as opposed to, you know, exposure, putting retractors in our hands and things. And so this is just something more reconstructive aspect. So in some folks, they might be born with an area where the kidney itself is not draining urine appropriately, and the kidney can get very swollen because of the poor drainage aspect. Whereas this is the contralateral kidney. You can see here, that area where the urine is draining is much smaller, right here at the tip of my arrow. Whereas here, that entire midpole, where the urine is collecting is very, very much stretched out. So a lot of times what we do is we'll have to remove that area that is not functioning well. And there could be various reasons. Sometimes blood vessels are crossing this area. Sometimes it just doesn't develop well. And once we've removed that area, we're able to connect these two areas to allow better linear drainage. And so this is an example of before and after. You know, people always love seeing before and after. And so this is kind of how the kidney is very swollen. Once we've decompressed that, taken out all that excess tissue and connected it linearly, you can see here how it flows very much easier. And a lot of this is just because of the magnification. And sometimes doing these things in a three-dimensional space, you know, where tumors are particularly, you know, if the tumor's growing into the kidney, you need to be able to look at it to get all around it, not just kind of not making linear incisions into it. And so that stereoscopic vision is very important. So again, you know, what makes robotic surgery useful is a lot of that articulation to be able to get around things, to be able to remove it, being able to, that magnification, letting us know exactly where we're putting our sutures to get blood control. You know, teaching education, you know, we all started from somewhere, you know, and so a lot of what we do is trying to bring in medical students, let them see some of this, let them get an idea of what the vision is like, then we also have models where we're bringing more junior residents or students in and letting them try practicing with just, we would have like two rubber bands together or peeling a grape. That's an oftentimes a useful learning tool. We try to get trainees to try to be able to peel the skin off of a grape and not get the meat of the grape. And that's a way of trying to teach that fine dexterity that you need in that three-dimensional space. So peeling, imagine a globe, trying to peel that tissue off of a globe. What are the cons? This is pretty much a lot of problems. It's not available everywhere. Like I said, St. Luke's is one of the draws was when I was first interviewed here, obviously it's been almost 10 years, but this is the first place that had a robot. And so we had a lot of utility. They'd already put in a lot of the fixed costs of developing a team. And those are things that we've been able to work on to really develop our program here. One of the things that's you don't get in robotics that you do is the tactile feeling. Sometimes, for sometimes patients could have a lot of different problems or diabetes or other problems where they could get calcified vessels. Sometimes you lose the tactile sensation of your finger feeling stiff, feeling the tumor, feeling where it is, because sometimes visual cues aren't always, what'll get you from A to B. And those are other things that, sometimes could be limiting. And so these are some of the things that are on the drawing board, so to speak, in a lot of the companies that are working in this technology, in this space, to try to improve it in future generations. And that's all I had. So this is just basically, I wanted to try to give folks an idea of what robotic surgery is. It's still a surgeon, cutting and removing and controlling and suturing and removing tissue. But we try to do it with smaller openings, less trauma, less blood loss to try to get faster recovery. And a lot of the reason for that is that patients being able to ambulate, walking around, getting back onto a regular diet causes less chance for pneumonias, less chances for blood clots. Those are the things that sometimes if you have a big incision, and it can be sometimes difficult to do with traditional means. And so that's just something about what robotics is. How do we use it in our practice here?